There are people in 27 different countries who are watching this event, so they've noted how bad we are at keeping to time. I apologize to those patient people watching online. Thank you for putting up with us. I hope we can entertain you with the next session. In fact, I know we can. We have 2 sessions between us and the end of the day. And these sessions are as important as the sessions that have come before. So that's going to be a challenge because that's a lot of information to discuss. But I'm very happy to know that the chair of the next session, Leena Mangani, who heads up the Access campaign here in India, is in charge of the next session. And as I warned the speakers, when Leena's in charge, Leena's in charge. So pay attention, please. She will keep us to time. We will ask all of the speakers to come up and take a seat up here at the panel. We'll still be taking questions at the end of their session. So thank you very much, and over to Leena.
So thank you very much for joining us after tea. And what I do have to say about this session is this, that I would believe that all of us are in some way familiar with exclusion and marginalization when we work with people in the communities that we serve. And so therefore I will replace the overlooked populations with the whole concept of exclusion and marginalization. And last evening I was just remembering Dr. Jonathan Mann, and he basically, as a lawyer, I just sort of look up to him as my school of public health. He said, why do black women get AIDS and why do gay men get AIDS? And I think we need to keep asking these questions when we work with the communities that we serve, because there are always populations that get left behind. In the following session, if you look at the agenda, you have adolescents out there who, legally speaking, are not adults and are unfortunately often treated as children or as adults and are often overlooked. Their needs are often overlooked. So I'm going to start the session with the thought process that we need to continue thinking about public health from the context of how we deal with exclusion, how we deal with marginalization, and how we deal with hard-to-reach populations. Some of them are on the agenda, including children, adolescents, and women. And I'm going to invite the first speaker right away. And Jemma is actually going to present from Uzbekistan. She's going to present a population that has been often overlooked in R&D, often overlooked in programs, by national programs, and I'm going to ask her to present the study.
Thank you very much to Leena for that introduction. So I will be presenting today an interim analysis of our results of a paediatric cohort taking the shorter multi-drug-resistant tuberculosis regimen from our project in Karakalpakstan, Uzbekistan. It's the same area that some of the earlier talks, or one talk, was given with an adult cohort, and this is the paediatric part of the same study. So for some context, Karakalpakstan is an area in the far west of Uzbekistan. It's a very large area, and as you can see here, it's this entire section of western Uzbekistan. It has a population of approximately 1.7 million people, and as was previously discussed earlier today, high rates of drug resistance, with 23% of new cases of tuberculosis having multi-drug resistance, and 62% of retreatment cases. MSF has worked in conjunction with the Ministry of Health in Karakalpakstan and Uzbekistan since 2006 in the area of multi-drug-resistant tuberculosis. The WHO estimates that 30,000 children will develop multi-drug-resistant TB each year. This is a population that has been neglected in research, with very little information available about children with multi-drug-resistant tuberculosis, and even less information available on treatment regimens, and this will be the first detailed description of children taking the shorter multi-drug-resistant tuberculosis regimen. Children seem to be good candidates for shorter treatment regimens because they tend to present with paucibacillary disease, so with less bacterial load, and logically should respond quickly to treatment and be able to have good outcomes with a shorter treatment regimen. Also, as we heard earlier today, that multi-drug resistant TB has significant psychosocial impacts for all people with multidrug-resistant TB, and it's particularly prevalent in young people, adolescents and children. In our area, a diagnosis of multidrug-resistant TB results in compulsory exclusion from school and other activities, which not only has academic implications, but also has implications for their social well-being and their connectedness with their peers. The WHO conditionally recommended the shorter multi-drug-resistant tuberculosis regimen for children last year in their update, but as I said, there isn't a lot of information available to back that up, so it's a conditional recommendation in the context of not very much data being available for this particular population. We've recruited children since 2013 we have ongoing recruitment at the moment. We will finish recruitment in June of this year. It's a prospective single-arm cohort study, and it's been conducted collaboratively between the Ministry of Health and with MSF in Karakalpakstan. We have ethics approval from both Ministry of Health and also from the MSF ethics review boards. We include all children, so that is people under 18 years of age, within the area who have microbiologically confirmed rifampicin-resistant tuberculosis, or if they're less than 14 years old, we include children who have a clinical syndrome consistent with tuberculosis and a contact with confirmed rifampicin-resistant tuberculosis. That's in part due to the difficulty in obtaining specimens for younger children, and it's difficult to establish their exact resistance profile. We exclude children with ofloxacin resistance because, as I will explain, fluoroquinolones are really the backbone of this regimen. And also, we exclude children with second-line drug use for more than 1 month before starting the regimen. With the exception of lymph node disease and pleural disease, we exclude all other cases of extrapulmonary disease. So it's only for children with pleural, lymph node, or pulmonary tuberculosis, and those who have contraindications to the study drugs that we use. There are 2 phases, as was briefly outlined earlier this morning, of the short course regimen, and that is an intensive phase which lasts between 4 to 6 months. The duration of that intensive phase is dependent on the timing of culture conversion. The later the culture conversion, the longer the intensive phase. For the intensive phase, we give the children one of the 2 available injectable agents, that is capreomycin or kanamycin, high-dose isoniazid, moxifloxacin, prothionamide, clofazimine, pyrazinamide, and ethambutol, and they take the drug 7 days a week under a directly observed therapy regimen. The continuation phase is fixed at 5 months, and we stop the injectable agent and the high-dose isoniazid and continue the remaining 5 drugs for those 5 months. Again, 7 days a week, directly observed therapy. The monitoring that we perform is weekly MSF nurse review and monthly MSF doctor review, and that's in addition to their routine Ministry of Health reviews. We also perform monthly smear and cultures. And in terms of monitoring for side effects, we perform routine ECGs, audiometry, visual assessments, biochemistry and liver function tests, and TSH. The children will be reviewed at 6 months post-completion and also 12 months post-completion, but as you'll see, we're relatively early in the data collection stage, so very few of the children have got to that stage as yet. At the time the abstract was presented, we had screened 32 children. We had excluded 10, enrolled 22, and withdrawn 3 subsequently. We had 12 children on treatment, and we had 7 outcomes. I'll go through those outcomes shortly, and also a brief update on some extra outcomes that we've had since the submission of the abstract. Our children are old children, as in they're teenagers. So the average age you can see is almost 16 years of age. We have 1 very young baby at 8 months, and the rest of them are mostly teenagers. And that's in part, as I said before, because of difficulty in obtaining specimens from young children, and also difficulty, therefore, in obtaining a drug resistance profile from that child. We have 59% female, 74% are culture positive, and you can see the denominator there is 19 because at the time of reporting there were still 3 cultures pending. 91% have only pulmonary TB, and again 91% have microbiological confirmation. The outcomes we had at the time of the submission of the abstract was 7, with 1 death, 1 failure, 5 treatment complete, and 12 continuing on treatment. We have now 2 further outcomes for a total of 9 outcomes, and those 2 extra outcomes are both outcomes of cure. So at the moment of our 9 outcomes, we have 7 successful outcomes and 2 unsuccessful outcomes, which is encouraging despite the fact that one of those outcomes is unfortunately a death. Adverse events are common, as with any multi-drug-resistant tuberculosis regimen. 60% almost of our children experience side effects. The vast majority of those are grade 1 and 2 side effects, and of those, again, the vast majority are nausea and vomiting. We've had 2 serious adverse events, that is grade 3 or 4 in the DAID scale. One is the previously mentioned death, which is a death that's presumed due to hepatotoxicity from drug toxicity. Unfortunately, at this time, the results of her autopsy are still pending, so we're waiting for full information about the circumstances surrounding that death. And the other was a case of significant QT prolongation, and that was in the context of an intercurrent illness. That child had appendicitis, and it resolved with the resolution of that intercurrent illness. That is the only case that we've had where study drugs have had to be temporarily stopped because of side effects. There are some limitations to our study. As I said, older children are overrepresented, and that's because of difficulty enrolling younger children on an empiric basis based on their contact drug resistance profile. And again, most of them are culture positive for the same reason. Again, also, we're early in our study time, so we don't have all the information at hand as yet, but the early results are encouraging for using the shorter course regimen in children, or at least in adolescents. We found that in general, treatment has been well tolerated despite our 2 severe adverse events, and recruitment has been slow for the same reasons. The TB is neglected in children because it's really hard to diagnose. We're excited about the future of multi-drug resistant for children. We're excited to see what the results of this study will be at the conclusion of the data collection period, and if we can finally establish a little bit of information about the treatment of multi-drug resistance in children, and also whether we can use the shorter course regimen in a context with high second-line drug resistance. It does have implications, therefore, outside of the ex-Soviet region, where children who have presumed or proven fluoroquinolone sensitivity would be good candidates for the shorter course regimen. We're also looking to the future to find even more tolerable regimens for children, and hopefully some that don't include injectable agents, because certainly for children that adds an extra level of complexity to their psychosocial well-being. I'd like to thank everyone involved in our research for their help in getting us here, and I would like to invite any questions if there are any.
Thank you for sticking to time, and I'm going to open the floor to questions. Quick couple of responses.
Hi, you mentioned in adverse events hepatotoxicity and in fact the fatal outcome. In Indian setting, we don't follow up the audiometry and visual analysis so much. So what is your take in respect to ototoxicity?
So we haven't had any cases of severe ototoxicity as yet within the paediatric population. Obviously that has extra implications within children, because especially for those who are pre-language development, causing hearing deficits has significant social impacts on their speech development. So far, we have not had any cases where there's been hearing impairments found. We do monthly audiometry on the children routinely, regardless of whether they have symptoms of hearing loss or not. And so far, it's all been okay. I know that in some of the adult populations described, there have been significant events, so we'll keep an eye out to see what happens through the rest of the study period.
And what is the duration of compulsory expulsion from school? Entire duration?
No, so at the moment, it's for the most part the duration of the intensive phase. So for these children, being able to shorten the intensive phase from the conventional regimen of 6 or 9 months down to the 4 months is a big benefit to them.
Thank you.
Yeah, someone just told me that the Supreme Court didn't even question the fact that children with HIV should go to school, and it's been incorporated in the right to education. But we're increasingly hearing about children who are being excluded from school because of TB. So I think it's quite a big issue. So I'm going to invite the next speaker, and I'm going to ask Jemma to So the next speaker is from Myanmar. Is going to talk about HIV in adolescents. And I'm going to make the attempt to pronounce her name, and hopefully she'll forgive me for all the mistakes I make. So it's Nan Nwe Yin Soe. And please welcome to India to make your presentation. Thank you.
Hello, ladies and gentlemen. My name is Nan Nwe Yin Soe. Difficult. You can call me Mina. Today I would like to present a study done in our project. The title is Clinical and Immuno-virological Characteristics of HIV-infected adolescents or ART in Myanmar. These people are who conducted this service. MSF is active in the Dhaka region since 2004. MSF project is comprehensive HIV care for high-risk group and vulnerable population in the Dhaka districts. In 2015, Myanmar had estimated over 200,000 of people living with HIV prevalence approximately 0.6%. Prevalence is higher in the high-risk group in MSN community, 11.6%, and in female sex worker, 40.6%. Approximately 5% of the total MSF HIV positive in Myanmar are adolescents. Many adolescents are born with HIV, which means many adolescents will be on ART for most of their life. Leading use of ART can lead to ciphers or virological failures. Adolescents have new peer pressure that they might deal with. For example, some adolescents don't like taking pills in front of their friends, which can cause problems with adherence. As we presented MSF Scientific 2050, as a cohort, HIV positive adolescents in Myanmar are less at presentation, stay on ART longer, and less lost to follow up, and respond better immunologically than their adult counterpart. In 2016, cross-sectional study done in our project, the method is all adolescents 10 to 90 years of age who present as January to April 2016 were invited to participate or enroll after informed consent. In this study, complete physical examination and laboratory tests. Laboratory test consists of CD4 count, complete blood count, viral tests, hepatitis C antibody, HBsAg, cholesterol, creatinine, complete laboratory tests. If viral more than 1,000 copies per ml, resistant testing was also done. Mental health assessment was also conducted by our trade counselor. This study was approved by the Ethical Review Board of Myanmar Ministry of Health and MSF. The graph shows cohort demographics data. In our study, 177 adolescents are participants. Out of 177, 96 are female. Their median age was 30.4 years, and their median time in our cohort is 8.4 years, and their median time or ART is 7.1 years. Average CD4 is 728. From the demographics data, not all adolescents start ART at birth. Many present to the clinic as children where they become sick. Out of 177 adolescents, 140 are first line on ART, and 37 are on second line and no third line regime. Among all 37 adolescents on second line, their median time on second line is 1.9 years. The reason why they changed to the second line was 34 cases reported as first line virological failure and 3 cases reported as intolerance of first line regime. Out of 177 adolescents, 168, 94.9% had anti-retroviral load. 9 adolescents had retroviral load and genotype dense. 7 adolescents had resistant mutation. The tall blue line shows the size of mutation on genotype. This graph shows the clinical characteristic of adolescents on ART. 74 adolescents have evidence of lipodystrophies. Lipodystrophy, which means abnormal fat distribution on the body. And 7 had neuropathy, which means numbness sensation of peripheral. And 1 adolescent had pH unit score greater than and 6 equal 6, which means minimal depressive. Most adolescents have past opportunistic infection before we start study. In our study, 101 of adolescents had previous opportunistic infection. TB is more common. 92% of adolescents had extrapulmonary TB and 6% had oral esophageal candidiasis, and 1% had PCP, and 1% had disseminated non-TB mycosis. From the social aspects of adolescents, out of 177, 127 of adolescents stay going to school. The others working as manual worker, daily worker, tailor, sailor, and some just stay at home and help their family. Most of adolescents are orphaned by at least one parent. In our study, 119 adolescents are orphaned. Few adolescents reported problematic behaviors. 10 reported about smoking, and 40 about drinking alcohol, and 1 reported illegal drug use. What we are going to do next is to analyze our qualitative data in the interview with adolescents. We would like to publish the whole studies or quantitative surveys and qualitative survey, when we will have more results from that interview. The conclusion of our study is adolescents had good immunological recoveries on ART and low level of current virological failures. Low level of virological failures, but many already changed to second lines. Adolescents and MSF HIV clinics adjust well socially and have low level of depressions. Counseling programs are likely helping their mental health. These are preliminary results of the quantitative surveys. We still need to analyze qualitative surveys where we will have more results from this interview. Thank you to all the MSF clinics and office staff who will help to provide the best treatment possible to many people, and thank you to the adolescents and their family who participate in this study, and thank you for listening.
So questions?
Hello, my name is Annette from Health Promotion and Community Engagement from Amsterdam. And I have a question. Because your adolescents do very well in the adherence, and I was wondering, even better than the adolescents, if I understood well. And I was wondering if you had special programs to support the adolescents.
Oh, well, yet in our projects, we have, we depend on their age. For the child, we divided, we call ACG. ACG means adherence counseling groups. The age from 5, 6, 7, 8 is ACG 1, like the age 6, 7, 8, 9, 10, 11, ACG 2, ACG 3, and over 50 years, adolescent. We try to organize to give the same appointment according to their age. And we have activity time mobilization trick every year according to their age. And we have peer support group every their appointment day. Yes. Thank you for the question. Yes.
Thank you. I am Dr. Dhyan. My question is, as you mentioned that immunological and virological outcomes were better in adolescents. What about the side effect, like neuropathy, lipodystrophy from the normal? Thank you.
Yes, most of the time when they take the ART, they take with stability. So most of the stability side effect with lipodystrophy. In my research, 74 adolescents have lipodystrophy, which means different the abnormal fat distribution. So when we see the patient, the adolescent is different with other adolescents. Their body structure is not like normal adolescent. Yes.
We took far too long to phase out stabidine. Before
But now, in our project, we phasing out G4D. We only use combination, fixed drugs combination, only one tablet at night. So the adherence is better. They don't need to take the pill in front of their friends. Just take at night, only one time per day. Yes. Thank you
so
very much.
Yeah. I'm going to, if there's one last question, if not, then I'm going to go over to the next presentation. So we have Jeroen van der Heijden from Bangladesh.
Pretty close.
Pretty close. So this is a study from Bangladesh. It looks at low resource communities and the health-seeking behavior. As we go across South Asia, thank you so much for your participation. I'm going to hand it over to you.
Good afternoon, and thank you very much for having me here today. My name is Jeroen, as already very well pronounced, and together with Nan Nwe from the Manson unit in London, we have conducted a qualitative study to better understand the health perceptions and health-seeking behavior of communities living in Kamrangichar and Hazaribagh in Dhaka, Bangladesh. Our study is titled Working to Stay Healthy. I'll take you through our study in the following 4 steps. First, I will explain a little bit more about the background and the study context, followed by the methodology, study findings, and finally the conclusion and the results of the implementation. This study has been conducted in the south of Dhaka, in Kamrangichar and in Hazaribagh, marked red in the enlargement. Combined, they are the biggest slum area of Bangladesh. Approximately 500,000 people live here on 6 square kilometers. That's 80,000 people per square kilometer. In comparison here to Delhi, it's approximately 25,000 people per square kilometer. So you can imagine how busy and how crowded this area is. Most of the labor here is done in the semi-formal industries of leather, plastic, garments, and metals. This area, and specifically Hazaribagh in the top red, where most of Bangladesh's leather production takes place, is one of the most polluted places on the planet, the 5th most polluted place on the planet, actually. In 2013, MSF OCA started an urban health care program to respond to the needs of this community, resulting in an occupational health program for male and female, and a sexual and reproductive health program for women between the age of 13 to 18 years old. At the time of this study, the program ran 1 main clinic and 6 satellite clinics. Currently they chose a more centralized setup, and the 3 marked in red, they are still remaining. So, rapid urbanization in middle and low income countries have resulted in a rapid growth of informal settings. Big cities have difficulties handling the influx of these uncontrolled growths. In Dhaka, it is estimated that the current 15 million people living there now will expand to 23 million over the coming 8 years. Working in these rapidly expanding and constantly changing settings is uncharted territory for MSF, and this came with a lot of questions and uncertainties. Running the program, it was realized that in contrast to the expectations, the number of patients visiting the clinic was low, despite the high population density and poor economic situation. The question rose why there was no bigger uptake in these free services. This study is focused on better understanding the way health is perceived and placed in the socio-economic setting of this community, and to answer, the answers of this study will help the program to tailor the services better to the needs of the community. This study was conducted amongst 40 patients in 3 groups: factory workers, women in the age of 13 to 49, and key stakeholders in the community, such as health workers, imams, and doctors. To enhance the credibility of our sample, we used purposive maximum variation sampling and divided the number of interviews over the 4 areas that I mentioned earlier. In this study, we've used participant-led interviews based on the topic guide. Because the study was conducted by 2 researchers and cultural gender sensitivity did not allow for interviews to be conducted by the opposite sex, we needed to ensure that there was internal validity between the interviewers. For this, we used obviously the topic guide, and we had a constant feedback loop between me and Nel, the second researcher in this study. As this study is a qualitative study in a rather unique setting, only the concepts of this study can be further generalized. However, this study itself can be used in comparison to similar settings or similar studies. A limitation to our study was that we encountered that a high percentage of the population was factory workers, which created a false division between the group women and factory workers. Even though at the start of each interview we made clear to what group they belonged, we still had significant overlap due to self-prioritization of issues. For this study, we obtained ethical approval from both MSF and the local board. So on to the study findings. Our study shows 3 main themes, which I will explain in further detail in the coming slides. First of all, health is seen as an asset to sustain a person or a family's socio-economic position. Secondly, contextual factors and barriers have a major influence on the decisions being taken. And lastly, in a fragmented healthcare system that is experienced in this area, informal networks are the most reliable source for search of qualitative care. So on to finding 1. First of all, people feel a strong responsibility to remain healthy. Obviously, we all do. But in this setting, it was the socio-economic limitations that was the single most persuasive determinant for health-seeking behavior. It was experienced, healthcare decisions were made in many cases a family decision, especially when it came to women. The family took a collective decision, and often this was linked to the financial implication. Many workers in this area work over 60 hours a week, hardly earning enough to make ends meet. Therefore, they lack the freedom to take the necessary measures to maintain their health. This status quo, however, is accepted in this community. Earning money is prioritized, and health is reduced to an asset or a tool for this purpose. In this context, time is money. So if self-care, meaning taking extra vitamins, rest, or extra food, did not quickly result in improvement of the symptoms, the first step taken was to visit a local pharmacy. Local pharmacies are available on every corner of the streets in Karakalpakstan. Here they were searching for a quick solution for their symptoms. Such actions have been proven to have a negative impact on the health of this and other low-income urban areas. At the same time, our study shows a level of mistrust and wariness. The pharmacy drugs were seen as a temporary relief, curing symptoms, not causes. And people are very aware of the risk of over-medicating. The motivation of their actions resulted from the commodification of functional health, as I mentioned before, to maintain the family's economic position. Decisions made were closely linked to the self or socially attributed seriousness of a disease. Experienced symptoms, not a disease yet. When a pharmacy treatment was ineffective, or when symptoms were unknown or the ability to work was tampered, the symptoms were seen as serious enough to consider seeking qualitative care in the form of a hospital visit or a qualified doctor. How am I doing with that? But once they went beyond the pharmacy, healthcare was characterized as a fragmented landscape of partial services, of which many were poorly regulated and varying in quality of care. This, in combination with inadequate secondary and tertiary care, ruled out a comprehensive healthcare system for this community. The limited knowledge that came with this in a highly fragmented and unregulated healthcare system creates a constant uncertainty on the availability and the quality of care for this community. People consulted different providers, often in quick succession, often resulting in differing diagnoses and incomplete treatments. In this context, formal health advice and support is poor. Choices informed by previous experience, recommendations of their own networks, and other care providers. While there's little evidence of information flows in urban slum communities, word of mouth seems to be the most important source of information for qualitative care for this community. However, in some cases, this obviously also resulted in contradicting suggestions, leading to further frustration by not getting the care that you seek. In conclusion, improving health in this complex setting demands a health system that includes a comprehensive healthcare model, tailored to the rapid needs and effective treatment for this community. This seems obviously logical, because that would be in every setting. However, in this specific setting, in doing so, there should be an emphasis on encouraging trust between the healthcare provider and the community. And thirdly, community-based mechanisms with an emphasis on health education will expand information and services flows, particularly to the most vulnerable groups, people in this community. Based on our study, a number of recommendations have been made to the project, and the project has implemented these. First of all, they have improved the access to our services. They're collaborating with factory owners to ensure attendance during work hours are possible, and they extended the opening hours of the clinic so people can also attend after work time, which was a big problem. Besides that, for the SRH pillar for women, the age limit went up from 18 to 25 to serve a broader group of women in this community. Further, they worked on sensitizing the staff and outreach workers on the importance of the relationship with the community and on building trust. And lastly, they're looking into the possibility of using word-of-mouth communication to spread health messages deeper into the community. Finally, I would like to extend a special thanks to Sabir, Adiba, Fatima, and the whole Karakalpakstan team, and to our translators for their support to this study. Thank you very much.
Oh, right away. There's a question right there.
Hello, Jean-François from MSF Brazil. I was just wondering if in the interviews came about alternative therapeutic options and health-seeking behaviors such as traditional, spiritual,
yes.
Personal.
Yes, it did come up, but it was marginal. They sought alternative health care, but for very specific diseases. Jaundice, sorry, I'm not a medic. That was one that came up most for the alternative healers, but people realized, they actually mentioned that They thought this was the better type of healthcare, but it took too long, and they needed a quicker solution. So that's why they went to pharmacies or beyond to a doctor. Does that answer the question? Yes? Okay.
Were you able to put these recommendations, implement these recommendations, and did you see an increase in patient flow?
Yes. Oh, I forgot to mention it at the last slide. We actually, I got confirmation from the project that they saw a significant increase of patients visiting the clinics. So it has helped. So I hope this was the reason, but yeah.
Thank you. A very important query I have, was the issue of mental health covered? Awareness. Thank you.
Well, it was a self-prioritized interviews. In cases, obviously, it came up, but it was not, that didn't come forward as one of our main results. Obviously, people deal with a lot of mental and physical problems in these areas, so yes. It did come up, if that answers the question.
Before we go to the next session, just a comment. I think it's a, oh, there is a...
Sorry, sir.
Did your part.
Okay. Myself, Fazal, I just want to have one thing that
Yes.
for the health-seeking behavior, which was the best community engagement strategy which was used in the part of the Bangladesh?
Which was the one that worked the best?
Best strategy, community engagement strategy.
Well, they're looking into, well, obviously they have an outreach team that goes into the community with the health message. We found in our study that the word of mouth is a very important tool, and trust is a very important element in that. People tend to doubt the health workers since they were not the only health workers in this community. There were other groups active that also spread a health message, and there were also groups active that went by doors to sell medicine. So there was also a mistrust towards our outreach workers. That's why we advised to use the word of mouth tool to get this message through key stakeholders in the community towards a broader group.
Okay, thank you.
Any questions?
Hello, I'm Mitchell. I'm the medical coordinator for MSF mission in Bangladesh. So perhaps I can add more on some of the questions and clarifications. Regarding the outreach questions, we have a huge network of outreach workers. So they are out in the community. So what they do is like they go house to house, give more information about our specific services which is available in our clinic, which is the services for the occupational health, services for the adolescent, sexual and reproductive health, and also the SGBV program. And we also engage schools, we engage college. We have a peer education group where we invite adolescents to come and have those health education sessions. So I hope that answers your question.
Some of the findings of these studies might be very important for AMR itself, because majority of poor economic migrants actually utilize antibiotics for a quick fix. And they're just trying to get back to work. And it's very interesting, I must say, for a lot of people who work in urban poor economic migrant settings. I'm going to go over to the next presenter. She's from Epicentre, and she's going to cover HIV and adolescents again. Perhaps one of the few conferences that has looked at adolescents so much, and that's actually a welcome this thing, please. We have Rose Burns.
Good afternoon, everyone. Thank you for the opportunity to present our study today. This presentation will explore treatment failure and expectations of perfect adherence to antiretroviral therapy through a qualitative study conducted with adolescents living with HIV in rural Malawi. So the study took place in Chiadzulu, which is a rural district in the south of Malawi, where MSF and Ministry of Health are running a HIV program which has included access to anti-retroviral therapy since 2001. It's a well-supported HIV program and it has very good outcomes amongst adult patients. However, we've seen that adolescents have high rates of treatment failure on first-line ART in the order of 30%. There's limited evidence to design an intervention that can support adherence amongst adolescents. So in this context, we've conducted a qualitative study which had the overall aim of exploring how individual social and programmatic factors could influence ART adherence amongst adolescents. Within this broader study, this analysis looks at expectations that are put onto adolescents within clinics, families, and the community to consider how they can influence adolescents' adherence to treatment. So we conducted in-depth interviews with adolescents living with HIV, aged between 10 and 19 years old, as well as people who influence their health-seeking behaviour. So that included caregivers, parents, aunties, uncles, community members such as traditional authorities and football coaches, also health workers. We did group activities using participatory methods that could generate discussion around HIV and treatment. These were conducted with adolescents who are inside our HIV program, as well as adolescents from the wider community. We had a total of 99 participants in the study. As is standard, we recorded, transcribed verbatim, and translated our interviews and group discussions. These were coded inductively, meaning we went through the text systematically to develop categories. These categories were distilled further, leading to the emergence of key themes and ideas that related to this research aim. We had ethical approval from institutional review boards in Malawi and the UK. Moving on to our key findings, we found that adolescents had really good knowledge about HIV and treatment. So they understood that it was important to take their drugs every day, and they wanted to do so to maintain their health. But these good intentions were often undermined by social norms and expectations of young people. These were manifest in the social spaces that young people inhabited, such as HIV clinics, homes, and communities. And in each of these settings, we found that adolescents' behaviours were regulated by strict rules and obligations, and there were threats of punishment for non-compliance. So attempts to exert control over adolescents' behaviours could actually undermine their adherence intentions. Within clinics, we saw a major focus on treatment literacy and imparting information about HIV and ART. Accounts from patients, health workers, and caregivers revealed that the messages that were received about treatment were unnecessarily strict. For example, regarding the timing of doses, taking doses with meals. Patients often missed a dose or gave up if they couldn't follow these instructions. And as one caregiver told us, for example, the medicine is supposed to be taken at 6:15 and instead one takes it 6:30. The medicine in this case does not work properly, the viruses keep multiplying and the medicine does not work at all. Patients also perceive different clinic approaches as punitive, such as pill counts, longer waits, or extra appointments that they were given if they couldn't follow clinic instructions. Other clinics also had similar approaches. In this case, we have a sign that was on the door of a so-called youth-friendly sexual and reproductive health clinic, and the translation reads, "To all yous, this is not a meeting place for you and your lovers. If found doing that, then you have broken our law. You will not be tolerated but given a punishment proportional to the crime you have committed." So that's a sexual and reproductive health clinic for youth. So adolescents appreciated emotional support that they received from staff, particularly counsellors, but there was also certain staff attitudes which undermined their engagement with care. They reported being scolded or shouted at. In the group discussions, we had adolescents draw a doctor, seen here in the picture and described as fat, frowning and grumpy and wearing expensive sunglasses. When talking about this doctor, one participant explains, "Other doctors are better off, but the kind we've drawn are those that cannot manage to stay for 10 minutes while explaining to them about your problems. They would even shout at you for delaying them." So as a result, adolescents were often afraid of discussing everyday challenges they faced with adherence. In households, caretakers rarely talked about HIV. It was a shameful topic, and when they did have a discussion, it was often to relay clinic instructions on adherence and to focus on the dire consequences of non-adherence. At the same time, actually adhering was challenging when adolescents were told to hide pill taking and their HIV status from other family members, and this often happened because of fears of inadvertently disclosing parents' status, given that vertical infection was the most common. One caretaker explained the extraordinary lengths that they went to hide medication in the house. They say, "Can you tell me where you hid the medicine?" "Okay, this is how I hide. There's a drum, and inside that drum there are books, and that is where we get these chairs so that no one will be interested to remove all those things in such a place. I also place the mattress on top. No one will step a foot in there." In this context, adolescents were left confused, anxious, and isolated. There was a group of adolescents who appeared to comply and did what they were told, a small group who openly rebelled, and another group who hid their failure by secretly skipping doses, by throwing pills into the garden or into the rubbish. In the wider community, we found that community leaders had held strong views about young people in terms of their expected roles and behaviour. Community leaders had far-reaching powers to influence social behaviour. They could impose fines or curfews or cancel social events. They often felt responsibility to address HIV-related stigma or to ensure that patients had good health-seeking behaviour. One community member describes threats to withhold healthcare from non-adherent HIV patients. He says, "There are others, they stay without taking medication, they just stop. So when we find such things, we give them a threatening advice that if they do that, they won't be received at the hospital." These threats often disempowered adolescents yet again. Limitations of this study were that it was challenging to collect information on socially undesirable behaviour like treatment adherence. The strengths of using a qualitative approach were that we could tap into a diversity of perspectives on the issue. To summarise, we found really good patient treatment literacy, but an absence of safe spaces to admit problems in following instructions or falling short of impossible expectations. Therefore, we propose moving beyond ART literacy, which is necessary, but it's not the be-all and end-all of adherence. We think it's important to work on life skills and problem solving through peer clubs, developing a counselling cadre inside of Ministry of Health. Secondly, we found that unnecessarily strict rules were communicated to adolescents about treatment. Therefore, we think it's important to prioritise more health worker training and adopt patient-centred approaches. And thirdly, we found that adherence happens inside families. So we need to work outside of clinical settings where children are taking their pills and support disclosure inside families as well as family-level stigma through interventions that include social workers, counsellors, home visits. So following this study, there's a new model of care that's under development in Chirad Zulu in MSF France project for adolescents. Lastly, I'd like to thank everyone involved in the study.
Thank you, Rose. So questions? So I'm just going to say that those rules wouldn't work on some of us even now. And I can just imagine telling a young person, you know, don't smoke, don't have sex, don't drink, don't meet your lover, and we are not willing to talk about your problems. I think adolescents are rebellious, and that's for a purpose. They explore the world through the rebellion. And I think we need to start thinking about delivering services quite differently to them. Yep. It's an excellent presentation. I wish more people living with HIV from the network were over here. And I'm going to go over to the last presentation, and hopefully at the end we'll have a couple more on adolescents and HIV. Thanks. So there's a video out here for the last presenter. She was not able to make it. And
unfortunately,
yeah,
we have to record this, so I'm starting it all over again. The study I'm about to present is online harassment, which is a retrospective review of records of Digital Rights Foundation. The background of it is that this, in Pakistan, women are not just inhumanely treated, there's a social inequality and gender bias women have to go through. The review of literature suggests that the impact of cyber harassment on mental health is worldwide and not just in Pakistan. Because of dearth of research on cyber harassment and its implication on women's mental health in Pakistan, Digital Rights Foundation
I'm going to tell you to stop the video and restart it, because I need to introduce the presenter. Is that okay? So the presenter is from Pakistan. She couldn't make her way to India. I'm going to leave the reasons for you to guess and discuss at tea. It's an issue that perhaps a lot of us are worried about as women, which is online harassment. And a lot of us actually do face online harassment, and it does have a mental health impact. And I think the Digital Rights Foundation does some exemplary work, and the presenter is from Digital Rights Foundation. Her name is Jannat Fazal, and despite the fact that she couldn't make it, she did make the effort to record the video so the message would get across to the conference. Thank you so much. And can you just restart the video?
Unfortunately, we have to record this, so I'm starting it all over again. The study I'm about to present is online harassment, which is a retrospective review of records of Digital Rights Foundation. The background of it is that this, in Pakistan, women are not just inhumanely treated, there's a social inequality and gender bias women have to go through. The review of literature suggests that the impact of cyber harassment on mental health is worldwide and not just in Pakistan. Because of dearth of research on cyber harassment and its implication on women's mental health in Pakistan, Digital Rights Foundation started a Hamara Internet campaign, which is basically challenging the threat of online violence. Hamara means ours, so basically it's for us, all of us. The need assessment for this research was done through Hamara Internet surveys. It included post-session quantitative research, cross-sectional design with convenient sampling. It was a self-reported surveys that measured technological access to tools of communication, degrees of cyber harassment experience, and digital literacy and awareness and legal rights. The results of that study, the survey that was conducted, revealed that majority of the women feel uncomfortable and unsafe on social media. As you can see, the 46% disagreed on feeling safe and comfortable on social media. The other result revealed that the 70% are afraid of posting their pictures online because they could be misused. So they just do not use internet or any medium or any social platform because they think that their pictures can be misused. On the basis of this survey, first cyber harassment helpline was launched in December 2016. The helpline was based on this Hamara Internet survey. The helpline includes 2 colleges, the helpline includes 1 lawyer who's trained in local laws, 1 digital security expert, and a psychologist who's always available for the calls. Cyber harassment helpline refers their cases to callers and their callers to helplines dealing with psychological issues, law enforcement agencies, and relevant government departments, for example, shelter homes and provisional women commissions. The objective of this study is, for Pakistan's first cyber harassment helpline, we attempt to describe the caller's emotional responses and reported effects on their mental health. The data that was collected was retrospectively reviewed from December 2016 to March 2017. It was a telephonic questionnaire, and the demographic information was taken, but no personal identification, no personally identifying information was taken to ensure confidentiality and maintain their anonymity. A descriptive analysis and psychological review was done. The ethics, the confidentiality, as already mentioned, was ensured, and no harm principle was upheld, which we tend to follow in our helpline. We do not take any personal identifying information, and we make sure that no harm is being done to the callers or the victims of cyber harassment. The results reveal that the total number of calls we received in 4 months was 513. Because that included follow-up, so the descriptive analysis was done on 406 calls, and the psychological review was done on 50 calls, because we had complete data for 50 calls, and I had taken those calls and I had taken those cases. So a psychological review was on 50 cases. So if we see the gender breakdown of the results, it's very surprising to see that 62% of harassment was reported by women. Out of that, 87 of the women were calling for themselves, and a few were calling on behalf of a family friend, family member, or family friend. The surprising thing here is that men also called for somebody else. 59% of men were calling for themselves, but the rest, 40%, call on behalf of family member or on behalf of a friend. Just because people are just not trusting towards the helplines, and there's a stigma attached to making calls and talking about cyber harassment. That is why they men had to call on behalf of somebody else. The result, if we look at the nature of complaints, so we had, if you look at the three peaks, that is fake profile, non-consensual use of information, and blackmail. So these were the most reported primary complaints. Fake profile means that somebody is impersonating you or appropriating your identity. Blackmail means to make threats and demands from the victims using their personal information or psychological manipulation. And non-consensual use of information is using, showing, disseminating, and manipulating somebody else's data without their consent. This most reported secondary complaint was gender-based bullying. Basically, women reported it because they were being harassed by men. It was the most reported secondary complaint. The psychological review revealed these recurrent emotional responses. As already mentioned, the data for this was 50.
I must say this is a growing area of work, mental health and the internet. and the fact that people are facing, young people and women are facing a lot of bullying and harassment online. And I must say this is one of the first studies that I've seen in this region. And I would encourage people who are interested in looking at it to contact the person who conducted the study and presented. I'm sorry for the quality of the video, but clearly the person was very passionate about the study that she had done on mental health of women who were facing harassment. I'm going to just open the floor for a last set of questions. We have a study from Pakistan, Uzbekistan, Myanmar, Bangladesh, and Malawi. And we've got, if there are any burning questions or any responses, please feel free to, before I close the session.
So I think there's probably a lot of common themes coming through some of the presentations. Some of the health topics are slightly differently. I wonder if a couple of the speakers would like to comment on what they think MSF needs to do better on adolescents in general, rather than maybe just, at least for the speakers who are dealing with adolescents.
And we have Petros in the room as well. Anybody who wants to comment on what we need to do better on adolescents and HIV?
Hello? Yep. Thanks for the question. I think in the setting in Chiradzulu where we conducted this study, it's clear that we need a tailored model of care, that the current model of care that's used for the overall cohort is working really well, but not for adolescents that are particularly vulnerable and need extra interventions. They need things outside of school hours, they need peer support, they need several of the other aspects that was spoken about with the Myanmar program. And I think that's what's being planned now in Chiradzulu.
Absolutely.
So I just want to make a comment for adolescents. We did a study a couple of years ago in Mumbai about adolescents with drug-resistant TB. So I take the opportunity to take two things from that study and from one of the studies that was presented today. So we found similar bad outcomes actually worse among drug-resistant TB co-infected with HIV patients who were adolescents. Like we found high mortality and loss to follow-up, not just treatment failure as our colleagues from Malawi found. This was actually one of the shocks that we had in our project in Mumbai, and we tried to reshape. But we didn't have the opportunity to have such good qualitative research as the one that I did in Malawi by Rose and her colleagues. And for me, that was my comment, like kind of praising such good quality work, because when we listen to the patients using qualitative methods and try to translate the findings of research into reshaping our adherence tools, for example, in this case. So we translate the study findings into action. It's one of the, let's say, gold moments of operational research, where really the findings guide our operations and hopefully change and improve them. And that was my comment. Thanks.
Yes, I'd like to make a follow-up comment. Is that, as it was very clear in Rose's work, the issue of judgmental, normative, moral approaches is a very strong issue when it comes to adolescents. And, well, I think the problem and what we can do is take great care that our own staff does not reproduce the stereotypes and normative and judgmental approach, because if MSF doesn't do it in its own spaces, then no one will, and this is the main issue with adolescents.
Thank you very much. I must say, you have a question? Okay, so one question here and one question here, and that's it.
Hi, Bhargavi Rao, MSF UK. Jeroen, excuse me if I'm not saying that right.
Almost.
I wanted to congratulate you on your study in Kamrangacha, and also it's been brilliant to have Mitchell, the current medical coordinator, in the audience as well, being able to say and follow up and give an update to say that the results of implementing kind of what your findings of your study have been really successful. And it goes back to Joe Puri's point earlier about the importance of doing research and evaluating the impact of the humanitarian action we're implementing. So here, you found something wasn't working, you looked at why, you changed the operation is now working much more successfully. Why don't we do more of this?
Well, that would be actually my plea to engage in way more qualitative research. I think in these times, MSF needs to be way more aware of where they actually work. They need to understand the community better, and what better way than qualitative or anthropological research. You see the outcomes here, they're already improving this project, so I would encourage all other projects to take same steps. Thank you.
Thank you, I'm Himanshu. Well, online harassment of women is a unfortunate contemporary phenomenon, and also systematically being used to shape conflicts as well. So how does humanitarian organizations like MSF see it, and where do we find ourselves to be involved in this space?
Inviting the speaker from Pakistan to highlight it was to start looking at the impact on mental health of online harassment. I'm so sorry. So I'm just going to very quickly say it's one of the first presentations of its kind, and it was work done by an organization in Pakistan. I am unaware of any such work in MSF, so I think we'll have to explore this further offline. Thank you. And thank you so much for being here, and we'll go over to the next session.